Okay. Good morning, colleagues. My talk address is a hot topic. In 2020, a landmark international consensus defined full endoscopic spine surgery as procedures performed with a working channel endoscope. It was definitely an important step for standardizing terminology in endoscopic spine surgery. But the same consensus also defined endoscopy-assisted spine surgery as procedures in which the endoscope is only used for visualization without instrumentation. The instrumentation would be performed through separate non-endoscopic pathways. And according to this consensus, UBE was labeled as an endoscopy-assisted technique, but this warrants re-evaluation in light of evolving surgical practice, growing clinical evidence, and the need for semantic precision. So today I'm starting with a difficult question. So what if we defined full endoscopy by the instrument that first made it possible, rather than by the principle that defines it? So last year we have published our vision on this on Global Spine Journal. Let's go back to the origin. So what does endoscopy actually mean? Etymologically, the term endoscopy derives from the Greek word endoskopesis, which means to observe inside. And this Greek origin defines the essence of endoscopy. Endoscopy historically refers to minimally invasive visualization-based techniques using optical devices. This means that the foundational principle of endoscopy has always been visualization. It has nothing to do with architectural design of the device that delivers it. So endoscopy does not mean working channel, it does not mean uniportal, it means to observe inside. Visualization, this is the central point. And if visualization is the essence of the paradigm, then UBE is not outside it. UBE uses continuous and exclusive endoscopic visualization, no reliance on other visualization methods, so it represents an evolution of the paradigm. If we advance from etymology towards the core principles, we may define full endoscopy in its literal and conceptual sense as procedures which are performed exclusively and continuously under endoscopic visualization and through a minimally invasive approach. So despite its biportal configuration, UBE fulfills all these criteria within a saline-irrigated environment comparable to working channel techniques. So let me be clear, the AO spine consensus was rigorous and necessary, but it was developed in a technological era where working channel systems dominated. So full endoscopic spine surgery became defined by the architecture of the scope, not by principles. Nowadays, this definition appears overly restrictive, as it overlooks the evolution of endoscopic spine surgery, the diversification of the endoscopic procedures, and the foundational principles of endoscopy, which is visualization. Meanwhile, UBE developed differently. So two portals, independent instrument motion, high-resolution imaging with off-axis viewing, continuous irrigation, exclusive endoscopic visualization, yet it was labeled as endoscopy assisted. But this is where the fracture begins. So because when classification no longer reflects operative reality, communication, data, and research become distorted. Meta-analysis separate techniques that share identical visualization principles, training programs split curricula that should be unified, and industry innovation becomes device-centric rather than vision-centric. Consensus terminology tends to crystallize around hardware rather than underlying principles. So why semantics matter? Full assisted, does it really matter? I mean, the debate is not merely about naming a technique. It is about the framework through which the knowledge in the field is constructed. If a procedure is classified incorrectly, that affects how evidence is generated, and it may distort scientific communication and create artificial divisions inside the endoscopic spine surgery. In our practice, this became impossible to ignore. So we are performing UBE entirely under endoscopic visualization, technique as in the full endoscopic technique, publishing outcomes comparable to other full endoscopic methods, and yet formally calling it endoscope assisted. There is a major conceptual dissonance in here. The operating room reality does not match the taxonomy. So the solution for this dilemma is conceptual. We have to step back to return to the first principles. What truly defines full endoscopy? It's not the number of portals, not the integration of channels, not the instrument trajectory. The classification of full endoscopic spine surgery should prioritize the method and the exclusivity of visualization over technical attributes. We have analogous multiportal endoscopic procedures, such as arthroscopic joint surgery and transnasal pituitary surgery, which are widely recognized as fully endoscopic procedures, reinforcing that neither the endoscope type, nor the portal number, nor the spatial separation between the instruments and the endoscope, these should not be factors that should preclude UBE from full endoscopy. Besides that, the term endoscopy assisted was already well established in medical nomenclature prior to this consensus, typically referring to procedures in which the endoscope complements other visualization modalities. For example, in spine surgery, these techniques involve larger incisions in hair-based environments and often include steps performed non-endoscopically, like fusion, for example. Also, in skull-based surgery, we often use endoscope-assisted microsurgical technique in which the endoscope shows the microscope's blind spots. So what changes if we accept this? Training becomes unified and under endoscopic spine surgery framework. Research cohorts became comparable. Meta-analysis become methodologically sound, and future guidelines reflect visualization principles, not instruments. And at the most important thing, endoscopic spine surgery community stops fragmenting itself. This is not an argument against working channel systems. They remain foundational and useful. UBE is not a deviation from full endoscopy. It is a diversification within it. And given the well-known advantages of UBE, it is well positioned to assume an increasingly prominent role in endoscopic spine surgery. While nomenclature must arise from expert consensus, we offer this perspective as a scholarly contribution to ongoing discourse. So we propose 3 steps. First, redefine by principle, not by instrument. Second, align terminology with surgical reality. And third, build consensus through data, evidence, and structured reevaluation. So UBE clearly fulfills all fundamental criteria of full endoscopic spine surgery and should be reclassified accordingly. We advance science by clarifying principles, and when we clarify the principle of full endoscopy, UBE stands not outside the paradigm, but as one of its most refined expressions. So I invite you all to read our paper on this theme, and thank you very much.
Thank you.
I'd like to make one comment as a Greek surgeon, because the term is very, very natural to me. But I was in a duel in LinkedIn a couple of months ago, and I don't want to get into duels, but you have to think about who gets benefit by underestimating a method which is less expensive. I don't have to say anything else.
Good point.
Thanks, President. So